There have been a number of questions that have come through on Slido related to Victoria State Police, and so we do have a couple of people from Victoria Police on this panel, so that's a good time to kind of play out those issues. I'm going to do what I did before and just read the list of our panelists quickly, and again, if I could ask you, because there have been a few seating changes, which is absolutely fine, but if you would be so kind as to raise your hand when called, that would be great. So from Victoria Police, Rena DeFrancesco, Manager of Sexual Offenses and Child Abuse Team. All right, and that's obviously with the Family Violence Command. Senior Sergeant Brett Meadows at Victoria Police. Julie Butler, counselor. Julie, yep, there we go. Southeastern Center Against Sexual Assault. Professor Louise Newman is down there at the end, Director of Center for Women's Mental Health at the Royal Women's Hospital. Kristin Hilton, Victoria Equal Opportunity and Human Rights Commissioner. So we have I missed anybody? Margaret, have we come to you? No, we're missing a couple of people here. Hang on. Here we go. Colleen Pierce. There's Colleen. Public Advocate Margaret Banks, whom I just spoke to, who's leaving early, so we're going to come to you early, Margaret. She's the Program Director at Australian Commission on Safety and Quality in Healthcare. Dr. Vinay Lakra, Clinical Director of Northwest Area Mental Health Service, and Joy Barrowman, Area Manager, Northwest Area Mental Health Service. So a distinguished and comprehensive panel, and we will move as quickly as we can to talk about some of these issues that we have before us today. So I do want to start actually with the police, if I may, because that's been something that we've not neglected, we knew that we'd be coming to it at this stage, but I think it's an important area because these two areas, mental health and police, can come into contact. So if we could, Sergeant Meadows, what can mental health services expect when they ask for or when you get an SO, do you pronounce it SOCIT, or that's how I would say it, or do you call it a socket? Does it have what's the acronym? Do you say the acronym or do you say the initials? I know exactly what it is.
We'd say the socket.
You say socket. It's interesting, acronyms can really kind of, blind us sometimes. So can you say for anybody who doesn't know, I mean, that's an unbelievably important acronym.
It stands for the Sex Offence and Child Abuse Investigation Team.
Right. So that is a team. That's a vital team. How does your interaction with mental health differ from a regular uniform response?
Look, a socket is set up with specialist detectives who investigate sex offence and child abuse. The frontline uniform, so the ones that we see driving around in vans out in the streets now, they'll quite often be the first that will attend when they're called. But as a general rule, once they've established that there is a sexual assault that's occurred, they'll then contact a socket, and then you'll get the specialist response from a detective from a socket unit.
And it's different. It's supposed to be different.
Yeah, look, a socket detective has specifically gone to that unit because they have a passion for this type of work. They undergo specialist training in this field. And they have an expertise in investigating sexual assaults and child abuse, whereas the front line generally, like experts in everything, but knowing a specific thing, they're probably lacking a little bit more.
And so if a mental health person requests socket, what can they expect when that team rolls, when you get that response?
It's hard to give you an exact answer to what to expect because the different incidences that you're going to deal with will all be different. Some will be of a lesser degree and others will be far more serious. As a general rule, you will at least get advice on a telephone, but generally you will get police attend, and they'll either be the frontline uniform or you will get a socket attendance. And once a socket member arrives, they'll then take over, they'll give you a lot of advice, they'll deal with the complainant. And if there's a crime scene, they'll process that crime scene and then investigate the matter thoroughly.
Just quickly, as you've listened to everything today, what are you going to take back to your team from what you've heard today?
As well as taking back to my team, I'll get to that in 2 seconds. I think the one thing I've heard here today is what we need to make sure we do is establish those relationships between those units and the local sockets. One of the things I'll take back to the sockets, because as our role we coordinate the 28 sockets across the state, is to make sure that if they are contacted by units that they do develop those relationships. If you don't have them, the problem you'll get is the response you get from the General Duties Police or even a socket investigator may not be of a standard that's good enough. Whereas if you develop those relationships, you have a contact point. You can communicate with them, you can go direct to the socket if that's the relationship that you've built. If you have an issue with the service that's been provided, you've got a point and someone to talk to about it, because there may be explanations as to why the service wasn't probably what you wanted. So the big thing I'd take out of this, and what I think you should all take back, is to make sure you build those relationships.
All right. We're going to do Francesco, if I can go to you now. There are a lot of myths and misconceptions about how somebody might act or behave when you get a sexual assault. How have you trained police to understand the evidence and to be clear on that?
So that's been a key part of a significant transition process Victoria Police has undertaken over the last 10 years. So about 10 years ago, the Victorian Law Reform Commission essentially criticised VicPol for having a culture of disbelief when it comes to this particular issue, for a lack of knowledge around sexual offending, why it occurs, how offenders set up relationships where they're able to continue offending against women and children largely, and also a lack of transparency in process and how police made decisions about which investigations to proceed with. So that was a significant wake-up call, I guess, for the organisation. So we embarked on a huge reform program, which included establishing 28 sockets. And critical to our sockets is they receive this specialist training, which teaches our members to understand the dynamics of relationships where sexual offending occurs, but also to understand myths and misconceptions. So we know that the community's understanding of sexual offending is not based on evidence or data or real experiences. It's based on a whole lot of myths about how victims should behave, how they should present when they first make a report. So we teach our members to understand that it is absolutely, it's uncommon for there to be injuries in sexual offence cases. It is uncommon for there to be any signs of resistance. It is very common for victims to provide narratives which aren't cohesive, which may change over time, which may appear to have gaps. That's absolutely normal reactions. So we try to... we've tried to build a culture that's really underpinned by a solid understanding of how these crimes occur, so that our members provide the best possible response to victims, but also know how to take their stories through a whole criminal justice process.
And has there been anything that you've heard today that will in any way inform or alter the procedures that you've already put into place as you've tried to change that culture?
Yeah, look, I think what we'll take back from today, what Brett's already mentioned in a very practical perspective, is to ensure that sockets have relationships with the right services in their area. But I think another area for us to move into, and this also aligns to the Royal Commission, their findings around the particular vulnerabilities that some members of our community have in reporting to police and staying engaged with police. So what we'd hope to do over time is that we increase the capacity and the capability of our sockets to be able to work with victims who have additional needs or additional vulnerabilities. So we already do invest a lot in how we take evidence from victims with cognitive impairment and children as well. So, but it's about building on that and looking how do we work with victims with other needs.
I'm going to do a little bit of a jump because I know that Margaret Banks does have to leave early. She's got a flight to catch, and I think it's really important to make sure that you catch that. Qantas and Virgin wait for no man or woman. So how does the NSQHS address sexual safety? These are the guidelines, the accreditation guidelines, and they're important. How do you do that?
Well, first off, I'd say they're not accreditation guidelines. They're standards it's a framework for safety and quality. Accreditation is always just a verification process. It's a moment in time. It's not nearly as important as actually putting the standards in place. Mm-hmm. The second edition of the standards this time round pick up the safety and quality the safety components of the National Mental Health Standards and build them into the work we do. But in addition to that, the standards themselves have been completely reshaped around a consumer-centred model. So the work that we've done around establishing an effective clinical governance framework, so the systems are in place to monitor and recognise and manage safety and quality. We've got a standard now built around providing comprehensive care, which focuses on and repeatedly throughout the standards talks about not just physical health but mental health. And while there are some specific mental health actions identified, there is also a whole stack of actions that relate to mental health without the label being added. So the standards are really about risk rating and managing risk and identifying and working with consumers and engaging and involving them in the process. Then, in addition to that, is the resources that are being developed. We've done a whole stack of general resources, but at the moment we're drafting up the resources that are about mental health services specifically and saying, look, for hospitals or services that provide care and you have a mental health component, there are important other things you need to take into consideration. And they are things like trauma-informed care. They are things like, have been raised out of the report that have come out today, and referencing them and using that information to build basically a guide for people to say, these are the things you need to consider as you're putting these standards in place.
So tell me a little bit about open disclosure in particular, because is that different when it comes to the sexual safety breaches from other circumstances?
Look, it isn't. The application of the framework applies. I guess the things that are different are that sexual safety, sexual health and sexual abuse is difficult for a lot of people to talk about. As you've already said, you don't see the harm, even though the harm is absolutely there. Because it's often psychological harm. The moral and ethical thing to do is absolutely to acknowledge and recognise harm. And I don't think, it doesn't matter what form of harm it is, everybody wants for someone to say they're sorry. They want to know why it happened, and they don't want it to happen again. So all of the elements that make up an open disclosure requirement sit there, just as they do anywhere else. So absolutely, the framework, the tools that we have are applied. They may need to be adapted to make sure that they fit the context in which the apology and the open disclosure is occurring.
Let's move, if we can, now to Julie Butler, because I want to talk about CASA, because, we've spoken about, again, this is sort of how we deal with everything. We've talked about the police and their response. Not everybody's familiar with CASA. What are some of the most common barriers when it comes to a referral and making sure that happens? And are there myths that affect whether or not a referral is made?
I think probably one of the most common barriers would be worrying about being believed, whether the person is feeling comfortable enough to take it to, particularly if you're looking at mental health areas, if they feel comfortable to take it to that person who's caring for them at the time. I think if that person could help them perhaps make a phone call to our service. Also, if the workers understand what CASAs do, we don't talk about the details of sexual assault. We find out about the impact that it has on the person, on their mind and on their body. We don't ask for the details about the sexual assault.
So who's the right person in your view if somebody's in an acute, because that's what we're talking about, the right to be safe, they're in an acute mental health unit. Who's the right person to make that referral, if you will, to CASA?
I'm not really sure exactly how it would work because I don't work in those areas, but I think anyone could make the referral, any nurse or support worker, family member, yeah.
Well, I think maybe that takes us to you, Professor Newman. Louise, I think there are these links between systems, aren't there, between CASA, between mental health, between various services that help people who've undergone traumatic experiences. How do you strengthen the links between those systems?
Well, big question, but to answer it as succinctly as I can, I think what we need to do is have a bit of a rethink about how mental health and trauma services work together. And the reason I stress that is because I think there are a group of consumers and survivors around the system who have both needs for trauma-focused intervention, as well as whatever mental health issues that they're suffering from, which frequently, as we've heard today, are a direct result of of early abuse and other traumatic experiences. So there's a group of people suffering, if you like, in the intersection of these two areas, and yet our systems don't reflect that. So
I keep hearing it throughout this, as somebody who's still a relative novice to the topic, and as a journalist, you all are the experts. But clearly this whole question of trauma-informed care, it's far more than a mandate for how to hold a conversation. It's really a way to engage with a consumer and an understanding. Can you play it a little bit more about what needs to happen in a comprehensive way?
Well, I take it a little bit further than that and actually saying we're probably overusing a very ill-defined term. Mm-hmm. Trauma-informed care means everything and nothing. And the nothing part, I think, is maybe what we should think about as the next part of the conversation that we need to have, which is about what does it actually mean in terms of service provision and helping people recover from trauma.
And for you, what is that? What does it mean?
Well, I think there are a range of interventions that we need to be able to have mental health and related systems actually offer that focus on helping people themselves recover from trauma, understand the impacts of trauma on the whole range of psychological experience, and give people strategies for dealing with that. And some people here would be very familiar with some of those approaches. We don't have enough evidence about about what's the most effective, but we do have some sorts of approaches. The problem that we have is that they're not usually available within our mental health systems. CASA services do, to acknowledge a fantastically important role in meeting acute needs and ongoing support needs, but they themselves are in many times struggling to meet in a better way the mental health needs of people who don't easily access mental health systems. We have our own internal, if you like, discrimination or stigma associated that people who are survivors of sexual assault and other traumas experience on a daily basis. Some mental health services are not particularly well disposed towards treating people who they might label, and we've had some discussion about this today, with borderline personality disorder or other terms that can be used to sort of belittle or disparage people. We need a reorientation, I think, of our clinical services in terms of trauma awareness, which is a bit more than trauma-informed care, because it needs to actually allow us to understand developmentally what trauma has done to people, how trauma continues to impact people when they're coming to our services, why it's so devastating when our services are fundamentally unsafe in many ways, but most importantly, what are we actually going to do about it? Where are the trauma specialists within our system? We don't have many.
Well, and just to link back to what you were talking about earlier, Helen, there's that whole sense of being able to say a story, to have a narrative kind of uninterrupted by the specific, fabric or rubric that a discipline uses and allows someone to tell their story. I want to move to Kristin Hilton for a moment. This report is entitled "The Right to Be Safe," the right. Not the desire, not the need, but the right. How does the Charter of Human Rights and Responsibilities relate, in particular, to mental health services and sexual safety as well, both?
Thank you. I think it's fantastic that the report is couched within a human rights framework, and listening to the previous panel, and I heard Indy and Julie speak very powerfully about it shouldn't just be considered that when you go into an acute or a unit that you are lucky or privileged to be treated in a certain way. That is a right. And what the Charter does, the Charter of Rights and Responsibilities here in Victoria, and we've had it since 2006, it's the only charter across Australia that we have in this state. So it's legislation that we can be really proud of. That enshrines those rights: the right to equality, the right to be free from cruel and inhuman treatment, and the right to privacy, which includes bodily privacy and bodily integrity. And when you go into a setting, a closed environment, if you like, or an inpatient unit, where those rights in and of themselves are limited by the very fact that you're in that setting, the importance of ensuring that those rights aren't further limited or restricted or infringed becomes more and more important. The other thing that comes along with that charter is not only does it specify or articulate what the rights of people are, but it also places responsibility and accountability on public authorities. Mental health service providers are public authorities, so they are bound by the Charter. And there was a report that was done in 2014, so it was 8 years after we had this piece of legislation in Victoria. And what the report found was that while there was a general awareness amongst the population and amongst some service providers that we have this piece of legislation, it really hadn't necessarily changed the way in which we deliver services, or the way in which we develop policies, or the way in which we make decisions, or even the way in which we advocate for people. So I think in this, that's why I'm so pleased that it uses the very powerful language of rights, because not only does that give a sense of dignity and respect to the people whose rights have been infringed or are under threat, but it does bring about that sense of responsibility. So both services and every employee that's within those services must understand how the Charter applies when they go about their daily job, and I think we need to make sure that we really embed that understanding and ensure that we are operating in a rights-respecting environment. The other thing that I would just say about reporting is that I've been speaking quite a bit since August last year, after the Harvey Weinstein moment, as we call it now, about sexual harassment and cases of sex discrimination. And we know that women underreport, and we know the reasons why women don't report sexual harassment. It's a fear of retribution, it's a fear of not being believed, it's a sense of shame, and all of those reasons are far more acute when you have a person who comes from who has particular vulnerabilities, or is in a particular setting where that sort of behaviour becomes normalised. And what we found through some of our research, we did a report a couple of years ago called Beyond Doubt, which looked at the experience of people with disabilities in reporting crime. And one of the motivations behind not reporting crime was that you didn't get believed, but also that the environment of client-on-client violence or violence that occurs or assault that occurs in a service becomes normalised, and it becomes categorised as behaviour management incidents, as opposed to a straight-out assault or an instance of harassment that needs to be dealt with properly. So I think moving from beyond... So we know that the onus just of having people report can be very, very difficult. So just relying, I think, on instances of reporting and targeting your interventions based on instances of reporting, which we've heard can be sporadic, is not adequate. You actually need a preventative culture, which is about going in, and we've heard about some of that, just listened to the last panel, heard about some of the interventions that are happening, within the Alfred and other service providers, but you need to understand how a rights-respecting culture is being developed within that service provision, and not simply rely on the person who is in there with extreme vulnerabilities to make that report.
I've got one follow-up on that, which is just that for this audience, what are the specific aspects of the law as it exists in Victoria, and more broadly as well, but specifically here, that they can utilize on behalf of themselves as consumers, or as carers, or as nurses or doctors? How can they use that law to ensure that sexual safety is guaranteed?
Well, it's not just within the Charter. We also have an Equal Opportunity Act, and that, of course, prevents discrimination on the basis of a range of attributes, including gender, including sexuality and disability. And again, that Act imposes a positive obligation on services providers, not just to respond to instances of discrimination or sexual harassment, which is also covered by the Act, but a positive duty to go in there and take progressive measures to actually ensure that the service that they're providing is equal and non-discriminatory. It also means that services have to make reasonable adjustments to produce equitable outcomes. So it might be, for example, that you have a policy or an operating model that on the face of it looks equal in terms of the way it treats both men and women, for example, in inpatient units, but the outcomes of that operating model are in fact quite inequitable. So it is a responsibility of service providers and government to make sure that those outcomes don't manifest. The Charter in and of itself doesn't have a dispute mechanism. So you can only use the Charter when you're perhaps invoking rights under another act, for example, the Mental Health Act. But it certainly bolsters the ability to make departments or service providers accountable. The purpose of the Act as well is not just about litigation. It's actually about trying to educate and trying to build a preventative and rights respecting culture. So we don't want to get to the Supreme Court around ECT or around compulsory treatment where the provisions or the rights or the law hasn't been followed. We want to use the Charter to try and inform what good practice looks like.
All right, let me move, if I can, to you, Colleen. So Colleen Pierce is a public advocate. You've got experience with the issues of sexual safety in acute mental health units. What's the role of the independent third parties when a sexual breach is reported to police?
The independent third person is a volunteer. They work with police. They sit in on police interviews wherever a person has an apparent cognitive impairment. So I say apparent because we don't require a diagnosis. Last year we sat in on around 3,000 police interviews. These good folk get up at any time of the day and night. They sit in there, they're not a substitute for legal representation. They're there to facilitate communication, to assist the person in the interview, and that might be an alleged offender, a victim or a witness, to assist them in communicating throughout the interview process. So the independent third person may say, look, they don't believe that the person is fit to be interviewed at this point in time, or suggest that the person may be very distressed and there might need to be a break in the proceedings.
So what practices do you think that we could put into place that make it easier and faster and better, frankly, to respond to a breach, but more importantly, that try to prevent the breach from happening in the first place?
Look, to answer that question, I need to talk about one of our other volunteer programs, the Community Visitor Program, another volunteer program. And I want to just pick up on what Kristin was talking about, and that's human rights. And I think we have to look at safety in the context of human rights. And community visitors are human rights monitors. It's all very well to say that people have rights, but they do have to be actively monitored. And our community visitors find a range of things. Last year in our annual reports, we reported on a whole range of issues relating to the safety of people in mental health units. They range from victims being left in the same units with perpetrators, unsupervised, people being left unsupervised in HDU units, vulnerable adolescents being left in units with older adults, the whole issue of language that Lynn talked about, and the notion of consensual sex and staff attitudes to that, how they respond to that, bed shortages that mean that there's often men in women-only corridors, and patients consistently report being unable to lock bedroom doors. So we have to be able to monitor the human rights of individuals, and community visitors are a really critical way of doing that. But typically what community visitors find, aside from identifying issues, is a culture in our mental health services where there is an unwillingness to be transparent about what's happened in the units themselves. And I think, Indy and Julie, you talked about the need for greater transparency, and we don't see that. We see an unwillingness for services to share incident reports with community visitors, so an inability for those visitors to monitor the human rights of individuals, an unwillingness to talk about those issues. Generally, well, not in all cases, I mean there's some really great examples, but certainly there is enough times that we are unable to look at incident reports and other issues for us to raise it with boring regularity with departments, with services, and with the Office of the Chief Psychiatrist.
So we talked about data earlier, but in essence what I hear you saying is that you need more data. You need numbers, you need incident reports, you need to know what's happening. Is that right? So that you can then follow up?
Well, we need access to that information, because in order to monitor the human rights of individuals in closed environments, and remember, community visitors are often the only people other than paid professionals, not entirely, but generally the only people other than paid professionals that are in these closed environments. So we develop a culture that we often need to protect. So access to information and data is really critical, and it needs to be available more broadly, not just to community visitors, but I certainly support the call for public reporting of incidents, so we know and that we can set benchmarks.
Can I just quickly, and I'm going to come straight to you, Vinay, but just a quick show of hands. How many of you would support on this panel the public reporting of data? Hands raised. Okay. Anybody else around the room want to raise your hand? I'm just kind of curious. That's very interesting. Okay, let me go to you, Vinay. That's just intriguing. So in terms of, let's talk about this, the breaches that can happen in the acute mental health inpatient units, and in particular, a number of people on Slido, and it's also come up in the panel, have talked about, is there, if you will, such a thing as consensual sex in these acute units, and what is being done to talk to staff in terms of monitoring and explaining to both staff and consumers what you think is the appropriate way to proceed.
Yeah, well, thank you. And it's quite good to be one of only few men to be on the stage. Trust me, we can contribute to this discussion. In my other role as the Deputy Chief Psychiatrist, I'm quite heavily involved in this, because I do the other role as well. But here I'm talking from the perspective of the service.
Two hats, right?
Two hats. And I think it, we've heard through the day, but it's not about an issue about safety of women or men or people with transgender or other sexual orientation. It's actually about the safety of an individual. And somewhere we kind of need to recognize that it's our responsibility, and we've talked about different legislations, that there is a whole of system response required to ensure that the individual is safe. And that is consistent with person-centered care and number of other things. So I think going into the gender debate is sometimes can distract you. But everyone's safety is important. And we saw with the data as well that, Helen presented about men and why men do not necessarily report. Anyway, the issue is underreported. We have made a lot of changes in our service, but, we are not still confident that all of the incidents are reported to staff. And to come to the issue of consensual sex, what we saw, we've done quite a bit of work over the last 2-3 years in this space. And every now and then that issue will come up to say that it's actually a consensual sex. We've talked to both the parties, they both are competent, they're saying, they're not alleging against each other. And actually, these are the majority of cases. The majority is not when somebody is alleging something against somebody. The majority is these kind of cases. What we started with, at Melbourne Health, we've had an initiative for the last 4-5 years about safety first. So where safety becomes first for everyone. And then I think I'm aware, a lot of people would know about violence in mental health services and emergency department. And so we focused a little bit upon a zero tolerance policy to violence. So we wanted to do safety for staff. And then when these issues came up, then we said, well, there's a zero tolerance for this as well. It's a safety matter for everyone involved. And so the first thing for us as an executive in our area was that at that level, we agreed that we would have a zero tolerance for it. So the safety of every individual is paramount to all of us. And then we kind of advanced that culture within the inpatient unit and within the community teams. And I can say that, we were a great leadership team in the inpatient unit. I see a number of psychiatrists here in the room today. Without medical leadership and without the leadership of the nursing staff, we could not have achieved that. And it was about having that conversation with initially the leadership group of the inpatient unit and then rest of the staff, that it is not our judgment to make that decision to say it's a consensual sex or it is not consensual sex. What we also found was that sometimes people change their mind later on. What seemed to be consensual at one point of time was not necessarily consensual at a later stage. And it was about having that clarity that staff were in a very difficult position to make those judgments at times. And I think I've talked about that actually there are not just two victims in this debate. There are actually more than two victims. There's a third victim. That third victim is staff. We don't do a lot for staff who witness these incidents, who see these events, the impact it has on them. Most of the staff have families. What does it do to them? How they need to be supported? So some of that stuff became quite apparent to us. And so really from that conversation about consensual, what we shifted is to say that it's not because consent is related to capacity. And so what we did was we shifted the conversation from a capacity issue to vulnerability issue. Because what we said to our staff is that when someone is unwell enough, and you need to know the Victorian mental health system, certainly, our length of stay is in days. The entire ward is turned over within a matter of 1 week. A 25-bed unit can have 14 discharges in 1 week. And so we actually, in that busy environment, we shifted that conversation from being of consent and capacity to vulnerability, because when someone is unwell enough to be in an environment as an acute inpatient unit, they are vulnerable. And then I think the question came up, what is our role and responsibility to protect that individual? Yes, they can make choice, they have capacity about certain things, but we've seen that how sometimes things can happen, and these things impact people on a longer term. And the other thing Joy quite regularly say is that we would want the same kind of services delivered to our consumers at what we would want for ourselves. And I think that's a standard.
That's an interesting point. So you want this to be a workplace safety issue in a way?
That's right. That's right.
So Joy, let me go to you if I can and pick up there with you. I understand that your service has taken the position that all incidents of sexual activity are to be reported to police. Is that correct? Do I have that?
That is correct. I'll just go back to that message that Vinay just described, is to treat others the way you want to be treated. And if you get that simple principle in place, then you work up from there. So that's where we've started from. And we've been working over the last 3 or 4 years on creating a safe environment for everyone. And this component of sexual safety is one part of it. So if an incident does happen, whatever sort of incident in relation to sexual safety, we do report straight through to SOCIT, straight through to the police, and I have to say they've been fantastic. We drive them nuts. If it's anything that looks like could be, we put it through to the specialists. The guys have been absolutely fantastic and respond to us every single time. Even the police on the beat, so to speak, if they turn up, they soon get SOCIT involved, and the sensitivity around their approach is just fantastic. I think it takes away and I think Lynn used the word grey matter. It takes away the blurriness for staff. We've got a range of different levels of experienced staff on our units. They're not the specialists in making a decision or investigating, and so we take that away from the staff. We treat everything as an incident and report it through to SOCIT, and they come in very sensitively and speak to our consumers and our carers and families too, because it impacts on everyone. And it's their choice. It's a choice whether they want to take it further or not. It can be parked for later on, and as Vinay said before, people are very vulnerable, very unwell, and may not want to do anything at that time, but at least they've opened the door and left the door open if they want to do something later on down the track when they're well.
And how has that affected staff, and how has that affected consumers? What is your experience with what
I think
changes?
it's taken the angst out of the decision whether to report. I think for staff feel much more reassured, because it's not just about reporting to police, it's also about escalation straight up through the governance structures as well. So it's a bottom-up and top-down approach. And the staff feel, and I've got staff in the audience out there somewhere, and I think they feel confident in that policy that we're actually got that practice. Not just a bit of paper, as everyone's been talking about, but that practice is in place. For consumers, and we do internal surveys around safety for our consumers and carers as well, and in fact, they feel safer with that environment. It is one component of many safety strategies that we actually employ into the unit. And I can go on forever on those ones too.
So, but again, I guess what you're saying is the right to sexual safety fits within the right to be safe. It
To be
is one
safe,
area
pull up.
of that. I see you, and then, yes, okay, go ahead,
Well,
and
I
then
think
Sergeant.
it's from staff perspective, it takes them out of that difficult position where they're kind of the judge and the jury and everything. And
Right.
so what we're saying is that you're providing clinical services, you make your clinical decisions, but we'll let other parties to do their bit. And I think the other thing, which, as I said, how these things evolve and you can change your mind and whatnot. But by doing that, it keeps that door open to not only further pursue this legally, but also to actually be able to get support systems around you. And I think one of the work we're planning to do is actually follow up when these incidents have been reported in the inpatient unit, to follow them up in the community over a slightly longer period of time to make sure that they've got that ongoing support. Yes, we provided information to them about CASA, that they have linked up with CASA, yes, they have gone and seen somebody about it, yes, they have accessed some of those services. That it is, because we know that these things impact people on a longer term basis. It's not something about here and now, I'll forget about it.
But it also sends a message too. So reporting to SOCOT and the police and escalation, it also you've got to prevent any other incidences coming along too. So it sends a message to our consumers, families, and staff that this is not on, and that if the perpetrator or whoever is the other half of that alleged assault is also addressed too. So it's just not looking at the one incident; it's also looking at what could happen down the track and preventing further.
Let me bring that excellent point. Let's go now to you, Sergeant, because I see you responding. And this does, of course, come to you.
Look, first of all, totally support those. They have to report. You need to ring police. We need to be told about these things. We will investigate it. It's not for staff to determine whether there's consent or not. That's part of our investigation. We'll call on the experts to try and work out cognitive impairments and whether they can consent. That's our role. That's what we do. You must report these incidents. We record them and we will keep track of these people. So if we don't proceed on this occasion and it happens again and again, we need to know who's doing what. It's important that you report all of these matters. Let us decide whether it's a crime. Let us decide if consent's an issue.
We've had not one rejection or delay in our response to our services, and the girls in the audience can vouch for that. So fantastic service. So thank you very much for the support. It's hard on the front line, and without you, we couldn't do it.
So what I'd like to do, I'm conscious that it's Friday and it's the afternoon, but what I'd like to do is I'm going to give each of you 1 minute. You're going to have to be very honest with your minute. And I want to end with Indigo and Julie, if I may. And I just want, as we wrap up, as you leave here and you go home and it's the weekend, it's going to roll back around to Monday. And on Monday, what are you going to do differently? Think about differently. What are you going to take away? So I'll start with you, and I'm just going to go straight down. I know you're stuck.
we are already in the action mode. I wanted to start by saying that we've been in action mode for last 2-3 years, and we will continue that and sustain that. I think I'm on call this weekend. I'll be there in our inpatient unit on Saturday and Sunday.
So you're not off this weekend, right? It continues for you.
We are into it, and this is the most important thing for us. It is about that culture in our organization that we take staff and patient safety seriously, and patient safety includes sexual safety.
All right, Joy?
I guess continue the fight. Everything we've put in place, it just continues to, continue the fight.
All right, Margaret?
I think the biggest thing for us will be about the consumer voice and targeting consumers in the development of the resources so that they're fit for purpose.
I think the most important thing for the Office of the Public Advocate is to really renew our links with, or reinforce our links with, consumer organisations. They've been very strong and they really drive a lot of the work that we do in the office. And I think the second prong is to reinforce to community visitors their role as human rights monitors, and not accept from service providers when they say, sorry, we can't give you access to incident reports, because that's the baseline of us being able to monitor the human rights of people in closed environments.
All right, Kristin?
Mine's an invitation for service providers, but also for consumers, if they want more understanding of what those rights that are in the Charter or the Equal Opportunity Act mean, not just in abstract but in practice, then we would love to be able to provide more information. And we also use contextual examples, and we also use consumers in our training as well, so that people get an understanding of what the impact of that type of rights infringement is and how you can avoid it from happening in the first place.
Yes.
Yeah, look, just on behalf of Victoria Police, make sure you do include us with any guidance and instructions you put together. If you're going to run training days around staff on how to respond to sexual assault, make sure you include us. We're more than happy to get involved. We will give you guidance on what to do when these things happen. And a part of that is making things safe, making people feel better about coming forward. We're good at what we do, and we can still get better, but we're pretty good. Just ask me.
Rena?
So I think the thing for me is I think we need to, as an organisation, improve our knowledge about this, the issues faced by victims in these particular settings. So that's something that we can start to drive. But we'd also like to share what we've learnt and how we've improved our response over the last 10 years with other sectors. And I'm going to use this moment to plug in some of our work. So if you haven't seen this, our Myths and Misconceptions resource tool is on the table there. It's a really easy read to help community and other agencies and authorities understand sexual offending so that we can provide a better response to victims. We also released a podcast last year, Victoria Police's first podcast series called Unspeakable, and that has a wealth of information that we hopefully encourages victims to come forward, but also informs the community about why this is such a difficult area.
All right, I'm going to come back to you two, Indigo and Julie. So if I go down to Julie and Louise at the end of the table, and then we'll come back to our consumers.
Keep on sending the referrals through to CASAs, helping your consumers to perhaps make the call, but also just something I was listening to earlier about reporting. I think it's important to remember what the consumer would like to do as far as reporting goes, because it's a really tough process, and CASAs can help them with that decision-making process.
Two points I'd take away. One, as someone who's involved in training mental health professionals, I think we need to do a radical rethink about how we're actually going to upskill our workforce to understand trauma, to understand the relationship between trauma and mental disorder, and how to help them move away from the DSM system and other diagnostic systems that fail to recognise the impact of trauma. My second point would be that we need to keep our work going in terms of trying to get more gender-specific, trauma-informed mental health services for women. Speaking with my women's hospital hat on, we have hardly any services around the country which with the expertise in women's mental health, and that by definition involves an understanding of child abuse and trauma.
All right, I'd love to, I'm going to bring Dr. Colson-Barr up at the end, but if I could go for the perspective, Julie and Indigo, of the two of you, that would be great.
Okay, so I've just got a few closing reflections. This may not be news to anyone, but basically I think our system is broken and it's crisis-driven. It's not working for patients and it's not working for staff. We need dramatic change. Many have come before us and the problems persist. This is an opportunity to address a failing, flawed system and associated culture in a comprehensive way. We have ways of changing this situation to give hope for genuine recovery to those who receive psychiatric services and those who provide them. My hope is that the Department and Government will acknowledge from the Mental Health Commission report the breadth and depth of the problems and commit adequate resources to address them. This necessarily involves dedicated funding, and we're talking serious funding here, not asking services for a wish list and then saying to implement it within their current funding. Just make it happen, it's a directive. All the goodwill in the world will not make this change without funding. This is no easy challenge. It involves answering some very hard and complex questions about service, treatment, responsibility, ethics and mental illnesses. An immediate example is the lack of accountability of perpetrators, which hasn't really been touched on today. How do we distinguish between bad behaviour and actions resulting from distorted reality? Is it okay for females to be subjected to harassment, intimidation and abuse simply because a perpetrator is unwell and has nowhere else to go? I think not. How do we make perpetrators responsible but protect them as vulnerable also? We need to work together as consumers and staff to come up with effective and just answers to these hard questions. On the thing of reporting, I'd like to reinforce what Indigo said and other people have said about reporting figures of breaches of sexual safety, and there's breaches of sexual safety I think is a bit soft. We're talking about rape, we're talking about physical assault, we're talking about psychological trauma and torture. And I believe this should be included in the State Government Annual Mental Health Report to Parliament, and that's for true transparency and open disclosure by government to the community. As Jaishree says, this needs to be a public issue to get movement. So I believe staff have the heart that brought them into the sector to keep searching for better solutions. Many examples of suggested best practice are woven through the full project report, so please don't just read it, think about it and take action. I'd also like to say thank you to Lynn and her team for taking on this task driven by complaints to the Mental Health Complaints Commission. This very forum is a welcome sign that structures put in place to support the recovery principles of the Mental Health Act are working. In order for consumers to recover, we need to reflect and recover as a system as well. The system is not just a backdrop to people's mental illness. It is an organic, symbiotic relationship, so let's not make it a damaging one. Together, consumers and staff can grow and flourish in an environment of healing, compassion, and the spirit of overcoming suffering. That's what we're all here for. Thank you.
Thank you. And Indigo?
Wow, thank you. I feel bad going on after that because that was bloody brilliant, Julie. I want to say a few things, and I'm going to take more than a minute. And I, as most of you who know me know, I'm proudly non-compliant because I think that's a strength. I've got many mates, I've grown quite a lot since I worked in the department as well, who are clinicians, which was a bit of a surprise for me, and policy people too, that's a bit of a surprise as well. And what I found after years of working mainly in a consumer space, I expected to find lots of really horrible people in the department and in the sector. I didn't think very nice things about you. What I actually found mostly was compassionate, smart people with a really good intent. So this is me softening you up, mind you, in case you didn't guess that. That is, but I want to say that because I think that's true. There are some bad apples in our sector, and many of you, if not all of you, know that, and we have to deal with that. But most of you are trying really hard, but that is not enough. It's not good enough. You need it to begin, but it's not good enough because people are being hurt. Many people's lives have been devastated and destroyed in this sector. There are a couple of things said on this panel that concern me greatly. And while I do appreciate, and particularly from people who are friends of mine, that there are impacts for staff very often that's hard in this sector, we have to be very cautious about saying something like the third victim is staff, because there is an enormous difference in almost every possible way. You guys get paid, you can leave, and you make the rules. We are in emotional crisis, we're forcibly detained, we're sedated, and then we're assaulted, and that is not the same thing, and we have to be very careful and think about power. That was just important for me to say, I think. So a couple of quick questions. I don't need you to answer today, but to think about what happens. How will the sockets respond if a consumer is sexually assaulted? And I agree with you, Julie, we need to stop saying breaches of sexual safety. Not a single person who's spoken to me in recent weeks has said, I experienced a breach of sexual safety. People said, I was raped, I was abused, I was assaulted. We need to be honest and respect people's experience. It's not a breach. It's a crime, and it's devastating. But if a consumer experiences this and they're not believed by a service, which has happened many times, what will happen if that consumer calls the police? Will we respond? Because we know that's been an issue in the past. How are we going to respond to that? If I ring and say, I'm in a hospital, no one will believe me, but I was raped. What can we do there? And the next step...
do we have an answer on the panel? Do we have a... Yes, Sergeant?
I'm happy to answer.
Yep.
It won't make any difference to me. I'd still turn out and attend to it as I would any other job.
Excellent.
All right, so there's a good answer.
That is
okay.
good. And our next layer on that, of course, something we haven't spoken about much today, and just to flag, but I really believe that our responses to sexual assaults of consumers by staff needs an even greater lens than our response to assaults by co-patients, and that's because of potential abuse of power. And it's also because many of the people that you serve in your services are people who've been to the Royal Commission, who've already experienced abuse in institutions, and what they've experienced in those institutions is cover-ups and hiding and secrecy, and Helen will tell you all about that, or you can read it in their big report. So we have to make sure we don't replicate that. We do not need to follow the path of all of these institutions. We need to be absolutely transparent and honest about what happens when people in a position of power commit a criminal act.
May I ask, are you calling upon the office to also look into assaults, sexual assaults, rapes, crimes by staff against consumers? Is that, yep, okay.
Yes, absolutely. I think we need to know what's happened in terms of professional registration. We know what many church responses have been, moving people to another area. I want to know, I think many consumers want to make sure that hasn't happened in the health sector, and I want to know about criminal charges and convictions, and I think consumers would want to know that as well. I'm not sure who does that, but we need to be absolutely above board with that. And so that's a point. I'm going to keep moving. We need to be, I know this is not a popular thing to say, but it's a truthful thing to say. I'm just saying all the unpopular things, really. No one will talk to me again. When someone has a wonderful, supportive, loving family inclusive practice is the best thing in the world. But we have to also be honest that many people live in situations of family violence or come from backgrounds of child abuse that happened in a family. And so sometimes family inclusive practice can be the most dangerous thing possible. And we have to be aware of that and incredibly discerning and thoughtful in how trauma-informed practice intersects with family inclusive practice. I've noted that one. Gee, that's good. I want to note with CASA. CASA was absolutely phenomenally amazing for me, and I've heard from other consumers that it was absolutely phenomenally terrible. So I think, we've got work to do, and to me, it reminds me a bit of the sort of conversations we had about 10 years ago about the gap between AOD services and mental health services and getting chucked between them. What do I do if I've been diagnosed with schizophrenia and I've survived child abuse and neither service has the skills to deal with my experience in totality? We've got to work on that. With trauma-informed practice, there's another thing that we haven't said, which is we've talked a lot about training the sector. The vast bulk of, this is probably the really wrong audience to say this to, definitely no one will buy me a drink, but the vast bulk of our workforce is nurses and doctors. And yes, we've got to train this workforce in trauma, much more than trauma-informed practice. But there's actually whole workforces out there who already have this specialty as a skill. There are trauma therapists, there are amazing counsellors, and actually there's incredible peer workers too. And so I think bringing our current workforce up to scratch is perhaps not the only part of the solution. I want to know why we're not flooding the sector with the people who actually have the specialist knowledge in what people need. And I know that's not very popular, but I think our workforce balance is wrong for what consumers need. Getting that one out. And when we talk about safety, we need to include psychological safety, not just physical safety. You are not keeping me safe if you cause me emotional harm. If you keep me alive today, but I am so traumatised that I will have nightmares for 5 years and eventually die from suicide, you haven't kept me safe. You've just delayed the harm. We have to be able to keep people safe emotionally and physically, and that's possible. And so my closing point is that while we've been here today, a woman or a man may well have been raped on one of our units. And someone else may experience that on the weekend, and then someone else on Monday and Tuesday and so on. And that's pretty awful. And I really want the last person that I spoke to who was raped in a unit to be the last person I ever speak to who was assaulted in a unit. And I hope you feel that too. So my call for you is to hold that thought in your head, that every day we delay and think about really long-term strategies and don't take action for change right now, another person's life is devastated. So let's all do better together, even with the really hard conversations. So thanks.